Mike Jackman. I am the chair of the South Shore Community Partners in Prevention. I want to welcome you all to the November meeting. This is probably the latest in the month we've ever had a meeting, in my memory anyway. We usually have it the second week, and of course last week was Veterans Day. And this is everything's different because of the pandemic, but we're glad that we have a chance to get together. I'm glad that we're still sharing programs, we're still networking, we're still able to find out what's going on with each other's agencies and groups and organizations and all the important work that everyone's doing. So that's why we exist as a CHNA, and that's why we're so happy that everyone's here today. I'm not going to do the traditional introductions where I have everyone say who they are. We will have time at the end for introductions, announcements. So if you do have a program you want to share, please, make sure you do that during the announcements at the end. As always, Kim Allen is on. Hello, Kim, our coordinator from United Way. And Kim does a great job with the email list and with the Facebook page too, in terms of getting announcements out, programs. So if you have programs, information you want to share with the community or let people know about, or let the rest of the membership know about, please make sure you forward those to Kim at CHNA23, CHNA23@gmail.com. So, we'll save announcements to the end. I did say we would be recording this, but if you would take a moment just to help Kim out with the attendance to put in the chat your email address. I think Kim does a pretty good job of noting from her gallery view, everyone was here, but if there are folks who are new or maybe aren't sure if they're on the email list, if you can put your name and your email address and what agency you're from in the chat, that would be really helpful to Kim in terms of keeping attendance. So thank you in advance for doing that. So we just have a little bit of administrative business to take care of, and that is approving the general membership minutes from October. Yeah, October. Kim does send the minutes around. If anyone has had a chance to review the minutes, I would entertain a motion to approve the October minutes at this time. George, is there a second? Nancy? Okay, thank you. Any discussion? All in favor?
Aye.
All opposed? Motion carries. Thank you. Minutes are approved. I don't know if Tyra is here. I don't see Tyra on my my screen or on the participant list, but we are really excited. As folks know, we have a steering committee. We have, I believe, a maximum of 15 folks who can be on the steering committee. And we've been at sort of 10, 11, 12 for the last couple of years. And we were excited, actually Kathleen, who's on the steering committee, recruited Tyra Jackson, who works at the DMH in Plymouth. And Tyra has agreed to be on the steering committee, but under our bylaws, we have to, the general membership has to vote her onto the steering committee. So Kathleen, I don't know if you want to, Tyra's not here as far as I can tell. Do you want to talk a little bit about Tyra and why you think she'd be a good member? Maybe we can have the vote.
I've known Tyra at DMH because I'm on the site board for the DMH in Plymouth, and I found her to be very involved and very enthusiastic and a positive influence with her clients, who, she's a case manager, but she has really gone beyond in what I've experienced. Nominating clients for various awards and, being at all the contract meetings. I think she's a really good person. I will add that she represents a minority, and that's just wonderful that we have another voice representing a diverse community on this committee. So I'm really happy that she agreed to be part of it. Thank you, Mike.
Yeah, thank you, Kathleen, for bringing her to the board. And I will say Tyra did attend our steering committee meeting as a non-official member, but had a lot to contribute. So we're really looking forward to having her participate. So Kathleen, if you want to make a motion to nominate her, Tyra, to be on the board.
I'd be happy to. I would like to make a motion that Tyra Jackson become a member of our steering committee for the South Shore Community Partners in Prevention. And I'm very delighted that I was able to get the name out correctly. Yes.
Is there a second to that nomination? George, thank you. Any discussion? I'm just only sorry Tyra's not here, but we'll certainly let her know the good news. All those in favor? Opposed? All right, and thank you, Tyra. Thank you all, Kathleen, and thank you all for voting her on. We're excited to add her voice to our discussions. All right, well, getting right into the heart of the meeting, as folks know, one of the main reasons we exist is to share the resources that we are able to obtain from the DON process from the healthcare providers in our district, the 2 hospitals and other providers. And we share those resources and distribute them to the community so that we can improve health outcomes for our residents. And we do that through grants, as many folks know. And once we give out the grants, we ask folks to come back and tell us what they did with them and how their projects went. So at this time, we're very happy to welcome back Mary Ellen McGuire-Eisen, who's the director of the Children's Melanoma Prevention Foundation. And she's going to tell us about her outcomes from her mini grant. I believe it's a mini grant, Mary Ellen.
It is. So thank you, Mike. I'm supposed to share my screen. So should I do that now to show you the PowerPoint?
Yeah, let me just make sure that screen sharing is allowed, and it is now. So let's see if that works.
Click share, and we're going to click on the PowerPoint, and we're going to share it.
There we go.
Perfect. So I am an oncology and dermatology nurse and the executive director of the Children's Melanoma Prevention Foundation. We started our foundation 17 years ago to prevent skin cancer 1 child at a time through education and advocacy. You may know that skin cancer is the #1 cancer in the United States with over 5 million cases, and 1 person dies every 45 minutes from skin cancer, and it's preventable and easily recognizable. So we have been teaching in the schools, but starting last year, we really couldn't meet the requests that we had. So we decided to apply for a grant, and which is to create Sunaware videos so that we could expand our reach in the community. So we were piloting these videos in the Plymouth school system, and we were focusing on doing 2 videos for grades 3 through 5 and 6 through 8. We partnered with PAC TV in Plymouth for creative media services. And after we received the grant, we formed an educational committee that was made up of a number of educators as well as myself, so they could advise us on content, on programming, on the length, which was really important because you know, when we're going into the schools, our program is usually longer, but this was designed for health educators to deliver. So delivery was important as well as the evaluation process. We recruited 3 health educators in Plymouth that were going to help us once the videos were ready to implement them in their classrooms. So that was really exciting that they were on board. We were at the same time going to have one of our Sunaware educators. So what we do in our program is we have 4 trained educators that usually go into the school and deliver our Sunaware curriculum to the students. So Martin Toohey had historically done it in Plymouth. He was going to continue to do it to half of the Plymouth students. So those 3 health educators would deliver the videos to approximately half of their students, and then we would have live programming. The goal of that grant proposal was that we were going to be able to evaluate these videos to see if they were as well received as our live programming. So our live programming is incredibly well received, with over 90% of schools rebooking every year. So we wanted to see if the students liked it. And so that was the goal. We were scheduled to shoot the video on March 13th, 2020. So we did do that. So we were fortunate to get in on March 13th to shoot 2 different videos. One of my son-aware educators, Maura Flynn, did grades 6 through 8, and I did the 3 through 5 curriculum. This was the last day that PAC TV was open to the public. So we were so fortunate to get in under that wire. As you know, the stay-at-home order came just 10 days later on March 23rd. But we were able to have 2 videos that were finalized and available by April 23rd. So we did share them, not just with Plymouth, but with all of the other CHNA 23 towns, which you can see there: Duxbury, Halifax, Kingston, Pembroke, and Plimpton. We provided links to these 2 different videos for those teachers to use in remote teaching. Teachers indicated that they would incorporate these videos into their programming. For additional video marking, and this was really exciting, we could no longer get into schools. We canceled 75 days of spring teaching once we had the lockdown. So we now had 2 videos that we could share, not only with the CHNA 23 towns, but also with all of our participating towns in Massachusetts. So we sent out those links to all of our schools. We also had the Massachusetts School Library Association share the links to those videos through that organization. And then Northeastern University school nurses, we work very closely, and they also shared our links to the videos. So it was a great way for us to get additional marketing. We didn't get as many evaluations as we wanted, but as you all know, teachers were very stressed out last spring trying to keep all the balls up and doing remote education. But these are some of the teacher comments that we received on evaluations. This education is more important than ever before because students are outdoors more. And that was definitely true last spring. Kids were out. The program went even better than I had expected because the students were really engaged. So that was terrific. And thanks for supporting my health class by joining our Zoom classroom. So Martin Toohey contacted all of the teachers in the CHNA 23 towns, but Maura Flynn, one of our other teachers, also offered program assistance, and she was able to join classrooms via Zoom where she could punctuate points, answer questions, and even demonstrate some of the technology that we use in the classroom. One of the things that the educators had recommended, so Linda Belokis, who is head health educator in Plymouth, said for the videos, create a wrap. And we had these 2 incredible professionals, we're down in Florida, who put our Son-Aware acronym, and the acronym includes both primary prevention of using sunscreen, wearing sun protection clothing, but also secondary prevention of routinely examining your skin and then educating others. They put it to music, and they did such a great job. And I'm not going to take the time to show you the wrap now. It is on our website. It's on our homepage. I think it was a home run. And we've incorporated it into those 2 videos, but I'm really excited to say through our collaboration with PAC TV, we've gone on to make 2 additional videos for K through 2 and 9 through 12. And those videos will be ready this week for us to get up on our website and share with the rest of our schools. So thank you to CHNA 23, because we were positioned to be able to pivot with this pandemic, which, you know, we had no idea was going to be the case when we applied for this grant last fall. So it was just so fortuitous for us, and I can't thank you more.
Great. Thank you so much, Mary Ellen. Does anyone have any questions for Mary Ellen? Mary Ellen, if you can stop sharing the screen just so I can see folks. Sorry. I will make a comment. You know, Mary Ellen, you've come in, you've presented to us many times, and it's funny the things you remember. You know, I can't remember as much as I used to be able to, but I remember once you said that the sun in the beginning of April, let me see if I get this right now, is the beginning of May is as intense as it is at the end of August, because sort of like July 1st is the pivot point for the sun's strength. And I always thought, wow, you don't think about like late April, early May being times where you can get sunburned. But especially this year, as you said, people were outside. I was outside more, walking more, trying to get some fresh air. And I was always very conscious of being out, especially that late April, early May period, of how strong the sun can be and how easy. And I burn anyway. So I'm always like lathered up and I got my hat on and doing all I can to keep out of the sun. But it's just funny the things you remember. I always remember that pivot point of July 1st.
Well, I appreciate you saying that, because in my experience as a nurse, and I've lectured from physicians to kindergartners, that's one of the most important things we teach, because here in New England, spring sunburns are so common. April is equal to August in intensity. May is equal to July. It peaks in June. Today, on this beautiful sunny day, the UV is going to peak at 1, and it's going to be 1 for the next couple of months. So UV intensity for the end of November, December, January is about 1. So of course it reflects off the snow, so we have to be concerned about that also, and reflective surfaces. But that is such an important point. I appreciate you making it.
Well, I'll still be wearing a hat when I go outside. It'll probably be a winter hat with the weather the way it is today. The other thing, I just want to thank you, Mary Ellen, and I know there's some other folks on the call who took part in our health fair. I know Jen Cantwell and Heather from Pembroke Hospital, and of course, I can't find my list now. I just had it on my computer. Amy Sandra was part of the health fair in October, so we really appreciate her being part of that. And the videos that we used in the health fair, we are going to try to get those up onto our social media so that folks can, so, you know, expand beyond the folks, just the folks who were able to attend the health fair that day. So Mary Ellen, thank you. It's great to hear that you were able to create those videos. Are those available to watch on your website, the videos you created, or?
So the presently, this moment, 3 through 5 and 6 through 8 are up. The Sunaware wrap is also separate if they just want to watch that. And hopefully this week, or at least by next week, we'll have the K through 2 and the 9 through 12 up. And the K through 2 one was done by Martin Toohey, who taught 2nd grade in Halifax for 30 years. And he did such a super job. I mean, it's like he's got the kids in front of him rather than the camera crew. So he did a super job.
Awesome. That's great. Well, thank you so much for coming back and telling us about that program. We're glad you were able to get those videos in before the shutdown. That timing worked out pretty well, I would think, especially because video is such a huge component of what everyone does. Yeah, can you just give the website one more time, Mary Ellen? Someone just asked in the chat.
So it's melanomaprevention.org. And we have a page for curriculum where it's broken down by the different discrete levels. Really easy to find the videos. I think our website's pretty user-friendly.
Okay, I just
go to what we do, educate, and you can go right down to the curriculum, and the videos are right there. Also on our resources page.
I put the website in the chat, but Kim actually put it in correctly, unlike me. So thank you, Kim. Way ahead of me, as always.
I was typing it anyway.
All right. Any other questions for Mary Ellen? I don't see anyone. So thank you again, Mary Ellen, and good resources to know about. So at this point, our main presentation is going to be from Dorothy Wisdom, who is a nurse practitioner with the Visiting Nurse Association. We're going to talk a little bit about end-of-life care. MOLST, which I actually had to look up. I know everyone's been saying, oh, we have to have a presentation on MOLST. MOLST, I'm like, okay, that sounds good. What does it mean? And I looked it up. MOLST stands for Medical Orders for Life-Sustaining Treatment. I think I got that right. So We're very happy to have Dorothy here today. Thank you, and I'll turn the floor over to you.
Thanks. Hi, everybody. My name is Dorothy. I am a nurse practitioner with the Palliative Care Program with the South Shore VNA. My background is pretty much entirely in hematology oncology as a nurse practitioner. I started in this position back in May, and I am providing palliative care to people in their homes. And I have I put together a PowerPoint, but I think I'm not sure. Kim, I emailed it to you. So I'm on Tina's computer, so I might not be able to get into my email to show it to you, but I have kind of the basics on my screen here that I can kind of just go by, if that's okay with you guys. So basically, I've always been a little bit preoccupied with end of life. I feel like even as a kid, I was sort of always talking to my parents about death, and you know, I was always very interested in sort of the process of death, and I always thought it to be something that I wanted to know more about. I used to read, like as a kid, I used to read a lot of weird books, and I feel like in as I got older and I went to school and I decided on nursing, some of my favorite classes, I took a death and dying class in college, and it was my absolute favorite class that I took. It was so interesting to learn about different cultures and different societies and how they deal with death, as opposed to our culture and society. And I think that it's just such an individual experience. And I'm happy to be able to kind of talk about that with my patients every day now. And so the reason why I got into palliative care after oncology was I felt that, in our clinic, in our busy clinic, it was hard to have these really difficult conversations with people, and really be able to educate them and talk about alternatives and talk about, the deep meaning of sort of what the decisions are that we're asking people to make and helping them to make those educated decisions. And so I feel like in the home, in the community, is one of the best places to have these conversations, because they're, in their comfort zone, they're surrounded by their family. Sometimes we're in their bedroom, you know what I mean? They're sitting in their bed because they don't feel good. They're, comfortable and able to kind of have these, very intense conversations. So when we talk about end of life care, so I kind of wanted to go over like the who, what, when, and where. So, who should be talking about end of life care? Who should we be talking to about end of life care? So, I feel like it's our responsibility as healthcare providers and community educators to open up the dialogue and to start talking about the what we'd like, what are we prepared for? Are we prepared for this to happen? Are we prepared for that time where we're going to need more help, we're going to need more resources, we're going to need more support? And I think that typically when I go in to see a patient, it's when they have what we call a life-limiting illness. So they're going through something, whether it be metastatic cancer, COPD, congestive heart failure, dementia. They're in the place of their illness where we can see that the end of their life is coming within 1 or 2 years. And sometimes the family wants me to come in to say, what can I do to improve this experience for these people? And what resources do I have to kind of help my loved one, family member, friend get through this time? And I think the problem is that sometimes family members don't know where to get these resources. They don't know who to call. They don't know where to look. And I think that, having a home-based sort of palliative care program that I've been able to kind of manage in this thing has been great, because through the VNA, they've been, the family members are saying, what am I supposed to do? How do I go about this? And so I can come in and sort of educate them about that. And it's a lot of coordination. It's a lot of, like I said, bringing in resources, but basically what an end of life conversation is it's a bunch of different things, but it's like, where do you want to be at the end of your life? How do you want that to look? What sort of experience do you want it to sort of, have you ever known anybody that's died before, and what happened, and what did you think about that, and what was the positives and the negatives, and that you thought happened, and in terms of the in terms of the overall experience, have you ever thought about that? And a lot of people don't, and I think that that's hard to kind of come in and be the first person to bring up this conversation, because a lot of people think just day to day to day, and that's just how they are. That's their personality. That's how they've always been. But some people are like, oh yeah, no, I already know, this is what I want. Nope, I don't want any of that. I want this, I want that. And those are to me, some of the, I kind of like that conversation, because I'm like, oh, you're a planner. I understand that. That's great. Let's talk about how we can make that happen. But it can be hard because some people are like, I don't know. I have no idea. I live by myself. I don't have any family. I don't have any support. I don't know. And that's very, very challenging. So I already went through the when. So, life-limiting illness, some sort of major impactful diagnosis that people are sort of dealing with. So who, what, where. But I think that's pretty much it. I mean, I feel like these conversations are not being had enough. And I think that it's our job to kind of bring it up in a way that's non-confrontational, that doesn't, bring significant amount of stress to people. But sometimes that's going to be unavoidable, especially in situations where, we've gotten to a point that drastic changes need to be made. And so I feel like it's our responsibility to foresee that situation and try to put measures in place to avoid that. So I just thought I'd go a little bit into the difference between palliative care and hospice. And then I was going to talk about the MOLST form as well. And actually, I had that in my PowerPoint. I'm going to try, while I'm here, I'm going to try to log into my email and then maybe share my screen. Is that okay if I did that? So the difference between palliative care and hospice. So palliative care is basically for people with a life-limiting illness. It is it's basically aggressive sort of symptom management in the context of somebody still wanting to have either aggressive treatment for whatever their disease is. So they say it's cancer. Somebody still wants to continue to have palliative chemotherapy or palliative radiation or some form of treatment for their cancer. And basically it's a supportive sort of system to go in and plan for what I just talked about, the end of life, like, try to see the issues and challenges that may come up and try to mitigate the stress that comes along with that whole situation. And also symptom management. So pain management, dyspnea mitigation, like trying to improve people's shortness of breath and their, if they have COPD, like helping to maximize their like functional ability while also making sure that they're resting and not becoming too short of breath with their daily activities. And then with congestive heart failure, managing their cardiac output in terms of like trying to mitigate the amount of edema they have and trying to keep their heart functioning as best as possible, but not really trying to the overall goal is to avoid and minimize unnecessary hospitalizations. So, what happens if you become short of breath? Let's think of ways to kind of manage that without you needing to go into the hospital. Because one of the indicators that somebody needs palliative care is if they have like multiple hospitalizations over a period of time, like say 4 in the past year, it can sort of bring up a red flag that says, okay, this person needs some help because they're failing and we're not sure what to do. Let's try to keep them out of the hospital. And then I go through sort of the advanced directive conversation. I go through the MOLST form. I go through the who are your primary caregivers? Who's your healthcare proxy? You know, have you had discussions with your healthcare proxy? Would you like to have a family meeting to talk about all of this together? Hospice is a insurance benefit that you have if a physician declares that your prognosis is likely to be 6 months or less. The benefit of hospice is that basically everything related to your life-limiting illness is covered by your insurance, whether it be private insurance or Medicare. And hospice teams work in a team. There's the nurse, there's a social worker, there's home health aides, and then there's the hospice medical director. And basically what they do is they go in and they form a team to kind of aggressively manage someone's symptoms in the event that they no longer want treatment for whatever their diagnosis is, say stage 4 cancer, and they no longer want chemotherapy for that. They're basically saying that my goal now is comfort. My goal now is to stay home. And my goal is to make sure that, the end of my life is something that I can have control over. And that's something I bring up. The control piece of this end of life care is something that I bring up to almost all of my patients, because I feel like sometimes in a situation where your, disease is, spreading through your body, or you're not able to breathe, or you're having all these symptoms, you can't always control that. But what you can control is how you want to be treated, what you want to happen, how you want that remaining time to look like. And I'll get to that a little bit more when I talk about the MOLST form too. But basically, hospice is a wonderful, it's a wonderful resource to have. And my impression is that a lot of people are afraid of the word, because they're like, oh my gosh, that means I'm gonna be hooked up to an IV, and I'm not gonna be able to get out of bed, and I'm not gonna, I'll die sooner. Well, actually, statistics have shown that people on hospice sometimes live longer than people not on hospice, because their symptoms are such aggressively managed, and they have such wonderful coordinated care that they're able to live not only better, but longer sometimes in certain situations. So it's one of my goals to kind of get people onto hospice as early as they can qualify, if that is if the philosophy of hospice goes along with their goals as well. And the longer that you're on hospice, the more you can sort of benefit from its resources. I'm going to stop here and see if anybody has any specific questions about hospice or palliative care.
I would just make a comment. You said you used the word control, and I think that's a huge factor. Just as an example, I'm one of 7 children, and my dad passed away from Alzheimer's about 12 years ago, I guess. And it was a prolonged, and it was not entirely pleasant for him. And we were all very involved with his care. And, my siblings and I would often talk about whether that would be something that we would want for ourselves. Mm-hmm. And we all agreed that that's not something we would want for ourselves, and not really thinking about how we could control that at the time. As it turns out, one of my brothers has a very serious cancer diagnosis, which he recently got. So it's almost, it's hard to put into words, but it's almost like one of the positives, if you can even say that, is that he knows that that's not what my dad went through, is not what he's going to go through, mm-hmm. Which, again, there's some sort of sense of control to that, which mm-hmm. I think he's getting some benefit from, actually. So I think that's a huge part of it, because sometimes when you get a serious diagnosis, you feel like you turn your whole life over to the medical system and you do lose control. So I do think that's a huge factor. I just when you said that word, it just really made me think about that.
Yeah.
So
On the same subject too, similar to that, it's like some people go to their doctors and, you know, they don't really say really what they want sometimes. They're afraid to kind of bring up, you know, a different scenario than maybe what their physician is recommending. And I find that it's great to be able to say, you know, you have control over this. This is your life. You know, I feel like it's important to have all of the information and be empowered to make a decision that's based on, you know, sort of what you want instead of what is recommended for you, because there's two sides to every coin, and you have to be very and a lot of times people don't understand what their physicians or nurse practitioners are saying. They're afraid because they don't want to say the wrong thing. They don't want somebody to stop caring for them, stop being their, you know, provider if they say, maybe I don't want that. And it's hard because there's all sorts of options available to people right now. And there's always like, okay, then we could do this, or this, or we could do those 5 things and then go to this. And sometimes I think that people don't want that, and they're afraid to say it, or they think that it's not acceptable to say that. And it's something that I've found to be very interesting in this job, because when you do sort of bring that up in conversation, people sometimes do decide, you know, like, yeah, I don't really want to do what I'm doing right now. I don't want to do this. I don't want to go to the doctor all the time. I don't want to, you know, do something that's going to put me at risk for being in the hospital. You know, I don't want to do something that's going to be at risk for me to be more symptomatic than what I'm experiencing right now, potentially, even, you know, because a lot of people don't know the statistics either, you know, because I ask them, I'm like, okay, so, you know, you're doing this right now, and what have you heard about sort of how much benefit is this expected to give you? Have you been given any sort of information and to be able to make an actual decision? And a lot of people don't ask, so because they're afraid. So it's kind of it's the control factor is something that this, I think, is really, you know, it's an empowering thing to give to people, and to make sure that they know that it's okay to do what you want to do. It's completely okay. So does anybody have any? I'm going to talk about some examples, some people that I have seen recently that I thought would be good to kind of give examples about.
Do you want to take a few questions first? I see a few hands up.
Yes,
I think
absolutely.
I saw Kathleen. Why don't we go Kathleen, then Siobhan, then Mary Ellen, and I see other people too. Kathleen, go ahead.
So I think I've had kind of an unusual experience with hospice because in my family, several of my relatives have had hospice care. And, you know, similarly to when you're choosing a therapist and you want to have a really therapeutic relationship, and if that's not possible with one therapist, I hope that people realize they ought to move on. So some of my relatives, and really there have been quite a few in several states with hospice, and I have found that hospice services in Massachusetts, and I'm happy to be able to say that because if I was somewhere else, I probably wouldn't be able to say this, are terrific. But in other states, they're uneven. And I'm thinking of one experience with a relative where we didn't have the confidence to cut our losses and move to another hospice. And so you talked about choice. And I think that that really is a really important piece to it, although it's unusual and I don't think that people talk about it very often.
It's true.
It's very real.
Yeah.
And if there's any time that you want people to be able to feel that they are being related to in the best, most positive, meaningful way, that is that.
Yeah.
So, 3 cheers for Massachusetts.
Agree.
Mary Ellen?
Yeah, so Dorothy, first off, I think you have one of the most important jobs in nursing. And in the book that Atul Gawande, the surgeon from the Brigham, wrote, Being Mortal, I was surprised to hear or read that 1 out of 3 oncologists do not have end-of-life discussions with their patients. And what you do is give permission to people. In my experience as a nurse, patients often wait for the healthcare provider to open the discussion. And if they don't open it, it's not had. So it's so important what you're doing.
Thank you. Thanks.
Siobhan?
I'm exactly going to echo what Mary Ellen was saying, that I think that's kind of the fear with hospice services. And personally, I have several family members that have tried to engage hospice services, and my family, I'm a nurse, but my family is very, they're wary. They don't, there's that fear of, well, now you're giving up. And I'm always saying hospice is about living better, not that's what it is. It's living better. It's having the better end to your life.
Yeah.
However long that might be. But I think that's the problem is, I'm not sure what kind of trainings doctors and especially primary care physicians have. And I think they feel that when we're engaging hospice services that they're giving up, and doctors are really not. Doctors and nurses, medical professionals in general, we're bad at giving up because we live in an age where technology and medicines are available, but they don't necessarily improve the quality of life. So that's the big piece, is having that conversation. And for me, hospice has been that expert to get that conversation rolling for my family members. I mean, I finally convinced my family to get hospice in for my grandfather, but they went the VNA route. And as soon as the VNA walked in, she said, "This is a hospice. We need hospice." And it was 2 weeks. And that, I know that's the average for people who are on hospice is 2 weeks, but you guys want more. You want to be able to build that relationship and have that life be better for longer. And I work for the Department of Developmental Services. When we engage hospice services, the whole team is ready. We've gone through any court stuff that we need to go through to get everything involved. And our folks live longer and better because of hospice services. And it's really a blessing to be able to have a good death.
Yeah. Agree.
Kathy? Yep. Kathy Dunn?
Recently, I had an experience with a family member regarding palliative care. And I think that is very scary for people. They don't realize that palliative care can be requested for management of difficult symptoms. You said this in regard to keeping people out of the hospital. And I just wanted to emphasize that palliative care is not the next step to hospice, as I thought, and my family member thought. So I just wanted to reinforce what you were saying with that recent experience. Thank you.
Thank you.
Great. Any other questions, comments? Maureen, go ahead.
I just wanted to add in, my mother recently passed away, but she was on hospice for 1.5 years. And I've told the story before, but I honestly believe she wouldn't have lived 1.5 years. She lived in her own home by herself with amazing support from hospice. And I really believe physically she wouldn't have made it without them, because she would have ignored some of her medical issues. They were there at the drop of a hat. They were able to address things. I can't say enough about encouraging people to get on hospice as soon as possible and allowing them to live exactly what you said. Her choice was to be alone in her own home as long as she could. And she did that till almost the very end. So I think it's just a discussion that needs to be had and explained to people that it isn't giving up at all.
Yeah.
Great. Yeah, the only other comment I would make just quickly is you talked about people not understanding the information sometimes from their doctor. And also, I think health literacy is a huge theme for us, and people being able to not only obtain information, but actually understand it and process it and use that information to make decisions. It kind of gets back to control. You can't control the decisions about your healthcare unless you're fully informed and able to understand what the different options are and, you know, some of the different concepts. I think part of that too is the importance of primary care and being able to talk to your doctor about what tests are available, to know, you know, to get that information as soon as possible. So I would just throw that out there because we're always talking about health literacy, and I think certainly this ties into that as well. So why don't you, it sounds like we have a few more examples you want to go through, Dorothy?
Yeah, I have a couple of people that I saw recently that I thought would be interesting to kind of go over the role of end-of-life care and you know, because in terms of having palliative care involved versus hospice versus, you know, people being discharged. Most of these people were discharged from the hospital to see me, right? They have VNA services and they're like, okay, so let's have palliative care come in. And basically, you know, I find that the discussion isn't being had with the family in the hospital. I feel like a lot of times in the hospital, doctors or nurses don't want to take they don't want to take ownership of that decision. They don't want to take ownership of like, these are your choices and this is what, you know, I recommend or whatever. They'll, you know, get them all nice and tidy, send them home with VNA, and then I'll come in and say, okay, let's talk, you know, let's have this conversation. But I think that that's a shame because I think a lot of resources that the hospital has, you know, more so than what I have, you know, coming into their home, I think they're missing out on that. So I think that some more education in the community just sort of about options, because what if the patient brought it up? What if the patient or the family was able to say, what are my options to go home? You know what I mean? Like, can you tell me a little bit more about what I'm looking at? Can we talk about the next month or two? Because people go home. For example, I have this one woman, 93 years old, lives alone in her apartment, and she's mostly wheelchair bound. She found out she has multiple myeloma, which is a type of cancer, and she doesn't want treatment. She doesn't want any treatment for that. And so here's this woman who, you know, has a home health aide, daughters work. They don't, you know, they're not able to be there all the time. She wants to remain at home, but she's already decided she doesn't want treatment. But when you ask her sort of, have you thought about death? Have you thought about dying? Have you thought about what you want that to look like? She's like, oh no, nope, I've never thought about it. Not once in my life have I ever thought about dying. And she's 93, you know? And so you wonder, so it's like, it's very interesting. You can't just assume that people have thought about these things. You can't just assume that people have like a backup plan. They have this like, what I call a TOE plan. It's like a time of weakness plan. Like they don't have that. Because they don't think about it. And it's either they don't want to think about it or they just never have. They never thought it would be important. A lot of people actually think that they'll just die in their sleep. And I can't tell you how many people I've talked to that are like, I'm just going to die in my sleep and it's going to be fine. You know, and I feel that typically those people are people that are older and that live alone, and they can't think about the idea that, you know, they might need help, that they might not be able to be in their home, or they might need people in their home where they've lived alone for so long. So I think that this particular case is somebody who needed a lot of coordination. It needs, you know, they needed hospice, and nobody ever brought that up. I feel that sometimes doctors, when somebody says, okay, I don't want treatment for my cancer, that doctors don't immediately say, okay, let's get hospice involved as an added sort of level of support. They don't talk about it. They send them home, or they, send them out of their office. They say, okay, let's get like VNA in, which is great. And then I'll come in and see the patient, but I don't have the, support system that hospice does. So anyway, my point with that story is that don't assume that people, no matter how old they are, no matter what their life situation is, have thought about planning for death. And another person is somebody who I met, who's again 90 years old, just got diagnosed with metastatic pancreatic cancer. He had nurses as daughters. They called me in to do a consult. The patient was sitting in his chair. The daughters were the ones that were talking. And I felt at a certain point that nobody's really addressed what this patient wants, right? Nobody's really brought the patient into the conversation, right? The one that's actually, who we're there for. And so the daughters were already talking about the appointments that he had for second opinions, possible radiation consults, all of this stuff. And I had to stop the conversation because this patient is his own person. He doesn't have dementia. He absolutely is aware of the situation. He knows what's going on. His wife was sitting next to him. Again, she didn't say anything either. And I had to tactfully sort of try and ask the daughters to allow the conversation to be between the patient and us, and what ended up happening was this patient said, I don't want any of this. I don't want to go through this. I have made peace with the fact that my life has come to an end. And his wife was sitting next to him. They held hands. She was crying. He goes, I have had a conversation with her. And the daughters all of a sudden were like, what? You know what I mean? They had no idea. They had absolutely no idea what was happening behind the scenes with their parents. But this is a situation where they didn't feel, the patient and the wife didn't feel empowered enough, or maybe they weren't given the opportunity to express how they actually felt. And it was a very interesting sort of scene to kind of all of a sudden unravel. People, I think, even the daughters were finally like, okay, I feel relieved now. What are we going to do? And we got hospice in, and the patient ended up dying within a couple of weeks. But I thought that it was it was a situation that I think would have been much more difficult to manage for the family dynamics and for the patient. And I think that in the end sort of it ended up working out well, because the daughters learned that the patient was accepting of what was happening. He had already talked about it with his wife. It was just a very, it was kind of a nice thing to be able to be involved in, and to kind of be able to happen at a time that I think was really necessary, because the patient was apparently very close to death. I have another patient. She's in her 80s, and she was bedbound. She had multiple comorbidities, like her heart, her kidneys, things were not working for her at all. She was in and out of the hospital constantly. And her family, it was an opposite situation. The daughter was her primary caregiver, and she was like, I don't want to see my mother like this anymore. But the patient had capacity. She kept saying, this is what I want. I want you to keep me alive for as long as possible, no matter what that looks like. I want CPR. I want to be intubated. I want to have a G-tube for nutrition. Even if that means I'm going to live the rest of my life in a hospital. And that was a very difficult case, because the family was seeing her, go through all of this. And during COVID too, they weren't even sometimes able to visit her when they needed to. And the point of this discussion is that that patient has the ability, no matter what, to make that decision about her care. She wanted that. She wanted to be, she wanted every sort of aggressive measure to keep her alive. And it's our job to respect that decision, especially when, she was her own person. She has capacity. She could make those decisions. And it's a challenge sometimes, but that is her control. She was able to make that decision. She ended up passing away in the hospital. But that's the thing. I mean, you have to ask people, what do you want? And that is what she wanted. She wanted to fight to the very end, no matter what that looked like. And that was hard for her family. But we have to just follow what the patient, we have to, do what the patient wants us to do. We have to honor that. So there's a lot of challenges when talking about end of life care. There's a lot of challenges with, family dynamics but that person, we went over risks and benefits of all of those things. And I always say, and I'll actually talk about this now, because I was going to talk about the MOLST form next, and that kind of ties into that. So, the MOLST form is a form. It's basically a portable, and this is something I talk about with all of my patients who have like a 1 to 2 year life expectancy. This isn't an appropriate form for somebody who's healthy in the community, sort of going through their day, working, or, even just an older person that doesn't have any sort of chronic illnesses. This is a form specifically for somebody who has a life-limiting illness. Basically what it talks about is, it talks about sort of the things that would be on a living will, like, what do you want to happen to you if this, if that, if this? And it's different from an advance directive, in that an advance directive is basically something that says, when I am unable to tell you what I want, in the event that I get sick, like, I'm not sick right now, but in the event that I get sick, this is what I want to happen. And it's sort of a guideline for people to care for that person in that event. What a MOLST form is as soon as it's signed, it is a legalized document to say that these are my wishes as it stands today. And it's a guideline, basically, and it's a portable guideline. This MOLST form is something that stays in the person's home. So it typically sits on the refrigerator. So if there was an emergency, somebody came to, the EMS came, and that person wasn't able to sort of say what they wanted, the emergency personnel would say, is there a MOLST form here, so that can help me guide what to do with this patient. This MOLST form is also, transfers to the hospital, transfers to the doctor's office, transfers to everywhere. You keep it in the car. This is sort of a wonderful way for somebody to have control over what they want. And it's something that a physician, nurse practitioner, physician's assistant can sign, and it should happen at the time of the discussion. And with COVID, it's been difficult with primary care doctors. I've seen a lot of primary care doctors mailing the MOLST form to patients. And my impression is that it's better to have the conversation while you're looking at the form and filling out the form together, because there's a lot of questions that people have, and there's a lot of education that goes along with trying to make these decisions. So there's 2 pages. I'm unable to share what it looks like, but if you wanted to, actually, I might have one at my desk, but I don't know if I held it out up, you would even be able to see it. But it's basically a form.
Do you want me to share it? I have
Yes,
a copy on my
yes.
computer.
Oh my gosh, thank you
That's helpful.
so much. That would be wonderful. So it's basically a 2-sided form, and you can fill out both sides. You can fill out just one side. It doesn't really matter. It doesn't have to be 100% complete, as long as one of the sides is filled out. So again, it's the Massachusetts medical orders for life-sustaining treatment. There's also there's these forms that are in other states as well. Thank you, Siobhan. Thank you so much. So as you can see, this is basically the most important sort of basic page that says, do you want CPR for a patient? If you were in cardiac or respiratory arrest, would you want CPR? And I typically go into this conversation with, excuse me, with you have to kind of give people an educated, some educated statistics to be able to make this decision. So I say, you know, have you ever had anybody have you ever known anybody, or have you ever witnessed CPR? Because it's not like you see on TV. It's not that, you know, you go down, you don't have a pulse, you know, somebody does CPR and then you wake up and you start talking again. It's not like that. It's actually very, very different. And statistics show that if somebody has an unwitnessed cardiac arrest in the community, they're basically, it's like less than a 1% chance for them to be, you know, to return to some form of prior functioning. So basically, like it's less than 1% chance for it to actually be effective, and for somebody to kind of go through that and for somebody to know that is kind of an eye-opening sort of thing to say. And they don't realize, a lot of people don't have a lot of understanding about CPR. They think that, okay, if my heart were to stop, they would do CPR and then I would be okay again. But it's not really, it's not the way it is. The people that get the most benefit from CPR are people that are in the hospital for cardiac reasons, right? So they're in there for an arrhythmia or something like that, and their heart were to stop. They were already in the hospital for cardiac reasons. Their chances of survival of CPR are probably within like the 20% range. But the people that I'm talking to about this are mostly people with multiple chronic illnesses, you know, people that, you know, are frail to begin with, that don't have a lot of, you know, ability, that the chances of CPR sort of working in that instance are, it's definitely within the, you know, 1 to 5% range. A lot of people are okay with that. A lot of people are like, yes, that's absolutely still what I want. That's okay. But you have to give them all of the education available for them to make that decision. So basically you educate them, you ask them, and then you fill in either do not resuscitate or attempt resuscitation. The second, so section B, is for ventilation, basically either intubation or non-invasive ventilation. I'll go into that a little bit too. So intubation is when somebody is unable to breathe on their own, and they need an airway placed and they need to be on mechanical ventilation. This is always done in the ICU. So if somebody were to tell me, you know, I want to be able to die peacefully at home, you know, I say, you know, that this is something that would make that wish sort of improbable, because, you know, being on a ventilator requires, you know, ICU level care, and that is typically in the hospital. Some people though say, yes, I want to be intubated, but then I only want it to be for like 1 or 2 weeks. And there's a way that you can actually say that on the back of this form, but I'll get to that later. And this is actually a very, it's a topic that is talked about a lot right now because of COVID. People are afraid to say do not intubate, because if they get COVID, they want to be able to have the chance to survive COVID. So a lot of people are actually indicating that they do want intubation, even if they don't want CPR. And this is a discussion that I've been having a lot lately with the community. One other thing I'll say about this is sometimes people say that they want CPR, but they do not want to be intubated. And that's a challenge. It's very, it would be almost impossible to perform CPR on somebody, get them back into a heart rhythm, and then not intubate them for respiratory support. So that's another challenge with education as well. And a lot of things that it's another thing that people don't always think about. The do not use non-invasive ventilation like CPAP. There's CPAP, there's BiPAP. Basically what that is that it's a way for people to get high flow oxygen into their lungs. And the reason why this is asked is because it is something that can be, that can feel invasive, even though it's typically non-invasive. And that's because they have a mask over their face that's pumping, you know, positive pressure into their lungs. And what happens is that because it's constant positive pressure, it's hard to exhale, and you have to work against that positive pressure to actually exhale. And it can cause a lot of people to feel like they're suffocating, like claustrophobia. It can be exhausting as well because their respiratory muscles, have to really be engaged and used to kind of do that exhale. And a lot of people, don't want to have that feeling of something on their face if it's something that's not going to be able to sustain their life for a long term. So that's a very, these are very difficult decisions for some people to make. And sometimes it takes a lot of ongoing conversations to be able to make an informed decision. The transfer to the hospital is another one that is sometimes difficult for my population. A lot of people, typically on hospice, they don't want to go back to the hospital. That's the first thing they'll actually say to me when I meet them. I'm like, what are your goals? And that's another, I'll get to that topic in a second, but what are your goals? And they say, I don't want to go to the hospital ever again. And so this is a good way that they can control that. Because if EMS came to their home and they weren't sure what to do, but, say it was something where, they were having trouble breathing or something like that, they at this juncture would say, are you too uncomfortable to remain at home? And they'll bring them to the hospital for support. But sometimes some people don't need to go to the hospital. Say it's like, something happened, but they're okay. But sometimes the people in the field don't really know what to do, or their default is to bring them to the closest hospital just because, 911 was called. So that's another sort of situation where that person can have control, because if it's somebody who's like, I still want everything done, I want the best chances of survival if it were something, then you could say transfer to the hospital. But typically the hospice population does not want to go back to the hospital, and a lot of the palliative population too. But if somebody doesn't want to be transferred to the hospital, you need to have resources in place to kind of take over if it were that person needs more care at home. So after going over all of this, the physician, nurse practitioner, physician's assistant signs the form, prints it, does the date and time of signature to make it legal, and then the patient signs it as well. And I typically go over everything again before the signature. The back side of this is basically about preferences. And this is where, people can further identify what their goals are. So if, for example, somebody says, I want to be intubated, but only for a couple of weeks at most, just to see if maybe I could get better, you could indicate that, yes, use it, but only for short term. And then if you can see underneath that little section there, it says other treatment preferences specific to the patient's medical condition. You can actually say intubation for 1 week max or something like that. And that will, that'll help the patient sort of know that their wishes are going to be seen. The CPAP, same thing. You can say only use it, but only for short term. Dialysis. This is something that people don't really think about. They think that they don't think of it as something to have on a form like this, but it can be a life extending procedure. And some people want that. Some people want to be able to, have that option for them. If their kidneys were to fail, would you want dialysis to see if it could improve your renal function and potentially, extend your life, even if that means you might need to be on dialysis for the rest of your life? Some people want it and some people don't. It's also okay to indicate, I don't know yet, and I would just do undecided. And then it would be something that we would continue to discuss over the length of our relationship. Artificial nutrition, like, TPN, G-tube, enteral feedings, things like that. So that is something that is a different that is its own, like G-tube placement and things like that. That's its own, I think, talk. There's a lot of different schools of thought about that. But this is basically like, if you were unable to eat, and you were also, unable to kind of tell us what you wanted, would you want us to keep you alive by giving you food through your veins? And a lot of people do not want that, because what that is just sort of an extension, like a life prolonging thing that could actually extend suffering. And this is what I bring up a lot of times when people have a question about that, and I say, at that point, it would be that you're not really able to kind of tell us what you want. And it seems that, with all of your other comorbidities and with everything else that's going on, it could extend your life, but I'm not sure in terms of quality what that would provide. And a lot of people have to think about this. They have to research it. They have to talk to their families, but it's a difficult situation for some people. It's a difficult question for some people. Artificial hydration. This is one that most people opt in for, and that's because a lot of times some symptoms at the end of life can be caused by dehydration, and a little bit of IV fluid actually can really improve those symptoms. Where it can get difficult is if that person maybe has some heart failure and that fluid goes into the wrong places, and it can actually exacerbate some symptoms. Some people are at the end of their life and they say, I don't want anything to keep me alive longer. That's not what I want at all. And they choose not to. But a lot of people do like the option of having some IV fluid for symptomatic relief at the end of life. So then again, I would go over, and then other treatment preferences specific to the patient's medical condition. So you can be more specific with the above, the things that we already discussed above, or we could say, they could say, I don't want x-rays, I don't want blood work, I don't want blood transfusions, or yes, I want blood transfusions, but I don't want IV antibiotics, and I don't want to go through any sort of x-rays or unnecessary sort of hospital visits, things like that. So that's where the person has the ability to kind of indicate that.
Dorothy?
Yes.
Yeah, sorry. I just wanted to make sure we have time for questions and announcements. So maybe, I hate to do this, but if you can sort of go through the form in like a minute or two.
Yeah, I'm done. Yeah, no, that's, I'm done with that. Does anybody have any questions about that?
I just had one comment, and number one, I just really quickly, I think that this is a wonderful forum. I like you talk to my family all the time about death and dying. And again, it's I don't know what my family would want. I don't know if it's the same as me. Right. And I think this forum, when it came out, I love it, that it's something that they can discuss with their primary care physician and really put it in writing, which we didn't all have an opportunity to ever do before this type of forum came out. Again, I work for the Department of Developmental Services, and just it's one thing that I know people don't often recognize, that people who are under guardianship, whether they're DDS, DMH, elder services, the guardian does not have the authority to fill this out just on the face of it. So I always like to make sure, because some people don't know that. But I love the form. I think it's a wonderful conversation, and I love that it should be filled out by their primary care, who knows them best, and has that relationship to have these really hard discussions.
Thank you.
So is this something, Dorothy, that you could ask your primary care doctor about?
Yes. Yep.
Okay.
But it's not, like I said, it's not always indicated for, the general population. Most people that have this form are somebody, like I said, with like a life-limiting illness, like metastatic cancer or end-stage COPD or CHF or something like that, or dementia.
Any other questions or comments? Well, this was excellent. Thank you so much, Dorothy, for the presentation. I think I had never seen the form before. I think it's definitely worth reviewing and thinking about, and talking to other family members about. I don't know if there are resources or maybe a copy of the form in the PowerPoint, Kim. Maybe we can share that if you do have that, or we can make sure with Dorothy and Tina that we have that, because I think that would be good for folks to take a look at going forward. And you definitely raise a lot of points, and there might be some questions that come in afterwards. We often have that happen too. So I really want to thank you for taking your time.
Absolutely. Thank you.
Yeah. Does anyone have any announcements? I know that Katie Mappa from the Family Resource Center had to jump off, but she put in the chat some links. Kim did send out information about the Resiliency Library that the Family Center has started. And I signed up. I think it's a great thing. And I think it'll be, it's a good tool to use to talk about different topics with your family members. So that's in the chat. And I know Kim also sent that out. I have one quick announcement to congratulate our Yeti contest winner, Caitlin McSweeney, who commented on our Facebook post and got it. There it is. She's rocking the new Yeti. All right. Congratulations. Personally hand delivered at a socially distanced, safely masked by your chairman. Thank you very much. Enjoy it, Caitlin.
Thank you.
Any other announcements? If there are no other announcements, I just want to talk for a second about our December meeting and see if I can figure out how to do this. We talked a little bit in our steering committee about, well, Thanksgiving is coming up, and we talked a little bit about gratitude. And I did a little looking into the concept of gratitude and what it, beneficial effects. There's an article which I'm going to try to share to the chat called The Grateful Brain. Turns out that gratitude has beneficial effects for resilience, has beneficial effects for dealing with anxiety. So not something I really knew about, but there's a lot of great discussion in this article. Gratitude, especially around this time of year, you think about, a lot of times I think around the holidays, we think about people who are less fortunate than us. And sometimes we use that as a way to compare our circumstances versus someone else's. And that's not really gratitude. That's sort of like a comparison. This article talks a lot about how gratitude can retrain your mind to think about positive emotions and getting positive feedback. And that helps in dealing with anxiety. So you're not always focused on things that you have to overcome, like obstacles. Like if you have obstacles, your brain is kind of hardwired to think about those obstacles. But if you have a grateful, gratitude-centered way of thinking, it's a way to overcome that. So we want to talk a little bit in our December meeting about gratitude, about how we're coping with the pandemic. We talked a little bit in our meeting about humor and how we are, some people are using humor to cope with the pandemic. Folks who know my Facebook page, I do a 30-day music challenge every month and ask people to post songs. I think music is a great way to deal with the pandemic. So if folks want to think about things that they're grateful for and how gratitude can be impacting their life, their work, I think that would be a great thing to share at the December meeting. We are going to have Jeff Stone, who is a grant recipient for the Community Food Program, talk about his program. We just awarded the grant, so it's not really an outcome report, but it's I think it's certainly timely for the holidays and the work that he's doing. Millions of meals hundreds of thousands of meals that he's providing to folks in the community. But also, if folks want to talk about how they're coping with the pandemic, how gratitude is helping them, I think that might be a good way too. So we'll put that out there in the announcement, but if people can be thinking about that, and if anyone wants to step up and share at the meeting in December, we'd really appreciate that too. We'd be grateful if you would do that. I am certainly grateful for all of you. I'm definitely grateful for my steering committee members who are here and those who are not here. We get a lot done in our steering committee, but we have a lot of laughs. We do have fun, but we do accomplish a lot. So I'm grateful for all of you folks. So that's all I really wanted to say about the December meeting. If there are no other announcements or no other pearls of wisdom to share, I think we can adjourn the meeting. Thank you again to Mary Ellen and to Dorothy for sharing with us. It was got a lot of great comments in the chat about what how helpful this meeting has been.